Okay. So thanks organizers for the invite and also for the nice topic for discussion. So for today's discussion, we have for PARP inhibitors in metastatic castrate-resistant prostate carcinoma. Of the last decade or so, we have seen a lot of changes, especially in the metastatic aspect of the prostate cancer. And yeah. So before going any further, first we understand what is a castrate resistance. It is basically evidence of disease progression, which could be either increase in serum PSA or on conventional imaging, new progression or new metastasis in a patient who has castrate levels of testosterone, which is 50 nanogram per deciliter. Now, this metastatic CRPC could be it is a spectrum. It can be a M0 disease where only a biochemical failure is there, or it could be a M1 disease state where metastasis could be there bone only, or maybe in the liver or other visceral disease. One thing we should remember is a presence of CRPC does not mean that the disease state is resistant to androgen targeted therapies, as was also said by Dr. Arpana in the quiz session. So, what are the treatment options for non-metastatic CRPC? They are guided by the PSA doubling time, and if the PSA doubling time is very high, that is, it is less than 10 months, then we have options like enzalutamide, apalutamide, or darolutamide. All these drugs have shown almost equal metastasis-free survival, and of late have shown OS benefit too. When we move ahead with the metastatic setting of the CRPC, the options are again many. We have abiraterone, we have enzalutamide in the pre-docetaxel, enzalutamide in the post-docetaxel setting. We have docetaxel as such, cabazitaxel, sipuleucel-T, or radium-223 for which should be treated as per the trial-guided inclusion criteria. Now, despite so many new drugs, novel hormonal therapies, the disease state remains lethal. The castrate-resistant hormone prostate cancer doesn't have a treatment which we can say is completely cured. There, in the search for new therapies, new alternative, new pathways comes in, and herein comes in the clinical genomics of prostate cancer. The genomic landscape across disease state is different. If you see the number of DNA alterations in the locally advanced but not metastatic disease, there are few alterations are there. But if you go to the metastatic CRPC setting, the number of alterations are many. In fact, 90% of the metastatic CRPC will have one clinically actionable molecular alteration. And most of the times it is AR pathway alteration, 70% incidence. And now we come to the fact that we have seen that there are about 20 to 30% aberrations in the BRCA2 gene, BRCA1, ATM combined, both in germline and somatic. So this is the early paper showing the incidence of BRCA2 germline mutation, which is around 9%, and BRCA2 somatic only, which is around 7%. Now, what I mean to say here is, combine these four gene alterations, it comes out to be around 25%. And to know that the patient has the mutation, it cannot be just germline testing. It has to be both germline and somatic. If you do only germline setting, you will miss almost 50% of the somatic BRCA2 mutations. That is also one aspect of this the therapy which will be related to HRR deficiency or the DNA repair enzyme deficiencies. Okay. So now, what is the rationale for PARP inhibitors, as was the topic for today? Now, PARP inhibitors are basically drugs which competitively inhibit the PARP enzyme. Now, PARP enzyme actually helps in the single-strand DNA repairs. Now, before going into how it acts, first we see what is a human recombinant repair gene complex. So these are this is, if you see, this is the double-stranded break. It is, if it is a break, it is sensed by the sensors, which is ATM, JAK2, it could be Fanconi anemia complex gene, it could be BRIP1. These genes or proteins would recruit the effectors, which will be BRCA1, PALB2, BRCA2, or RAD51. And once this is there, the DNA gets repaired. Now, whenever you inhibit or you give a PARP inhibitor, which is basically, if you move ahead, it will be better understood. Now, if you see this particular section, the middle one, we have a cell whose HRR system is competent, it's active. And then you induce PARP inhibition, the single strand break is not being repaired, but the cell survives. Whenever, on the other side, if the HRR is deficient in the cell and you give a PARP inhibition, both of these together act and the cell doesn't survive. This is called synthetic lethality. What I mean to say is, if any one of this is absent, suppose we give a PARP inhibition and HRR is not deficient, the cell is going to survive. And in the other way around, the cells we know have mutations, but they don't get killed unless until the PARP is active. So this is how the synthetic lethality works for PARP inhibition. Now there are 5 PARP inhibitors which are currently known or which are under trial. And amongst the well-known is the Olaparib, the other one Rucaparib, Niraparib, Veliparib, and Talazoparib. So Olaparib we know has been approved in ovary and pancreatic cancer also, and of late in breast cancer also. For prostate cancer, it was the earlier studies, the TOPARP A and TOPARP B, which showed the overall response rates of around 40%. And then the phase 3 trial, the PROFOUND trial came in, which is the Olaparib for metastatic castrate-resistant prostate cancers in NAGM by De Bono. So what this trial did was it took 2 cohorts. The cohort A had specific genes of BRCA1, BRCA2 or ATM alterations. The cohort B had all the other alterations which are linked with the HRR repair complex genes. Both the cohorts had 2:1 ratio division against Olaparib 300 mg twice daily versus physician's choice of drug, which could be either abiraterone or enzalutamide. The thing is, we have the cohort of patients, both the cohorts had actually metastatic CRPC, which progressed on a novel hormonal therapy agent, which could be anything before the progression. Also, there was crossover was allowed in the physician choice cohort if the disease progressed. So what we saw, the primary endpoint of image-guided progression-free survival, radiographic progression-free survival, was markedly increased if the Olaparib was given to the tune of hazard ratio of 0.34. Also, we saw that the patients with BRCA2 mutations had better responses and longer PFS than BRCA1 or ATM. With respect to OS, this trial showed us that there is about hazard ratio of 0.61 in the BRCA1 BRCA2 cohort, and that means around 40% benefit and less deaths when the treatment is given with Olaparib. But we know that most of the patients had crossover from the physician's choice arm to the trial arm. So it was 80% of the patients who had crossed over. And once you adjust this crossover, the hazard ratio for OS comes out to be 0.42. That means 60% less deaths. This trial established the role of Olaparib in biomarker specified patients where we can see the HRR mutation is there, we can see BRCA1, BRCA2 mutations are there, and we can prescribe them Olaparib depending on the inclusion criteria as per the trial. The drug is almost has no major side effects, mostly hematological, and most common amongst them is anemia. We come to the second drug, which is also approved by FDA. Now, this is the Rucaparib, and it was the Triton 2 trial. It was a phase 2 response data, which showed an overall response of 44%, and just because of this response, it received accelerated approval from FDA for such settings. The difference in the 2 trials is basically just that the Rucaparib included patients who had prior received taxane-based chemotherapy and are now on metastatic CRPC progressed. Otherwise, most of the HRR gene which was included here is the same. What we saw in the Triton 2 study was also that irrespective of whether the mutations are germline or somatic, the responses were present. The mutation is present, responses are present if you give PARP inhibitors. So the other trials, which I'm not going into details, are again phase 2 right now, and they have also showed the overall response rates of 40%. And further phase 3 trials are still awaited. The results are awaited. So this, what we have discussed till now, is just the PARP monotherapy. So where we have seen that we are giving one drug in specifically patients who have DNA repair genes mutated, and that's how the response we have seen. The sequencing would be like after AR targeted therapy, that is abiraterone and enzalutamide, we can give olaparib as per the PROFOUND trial. As I said, for rucaparib, we also include after the chemotherapy if the patients have progressed. But one thing which is again noted, which is different and which is more interesting, is that the combination of PARP inhibition with other novel hormone therapies in absence of germline or somatic alterations. Herein, we see something called BRCA-ness or a BRCA-like phenotype, meaning hereby that there are no germline or somatic mutations, but the trial showed that the androgen deprivation therapy or enzalutamide leads to a state where there is downregulation of DNA repair genes. That means it is increasing the sensitivity to PARP inhibition. With this concept, we had the first phase 2 trial, which was in 2018 by Clark et al., which compared patients with metastatic CRPC who have been pre-treated with 2 or more lines of chemotherapy. And we have combined olaparib with abiraterone. We have combined abiraterone with placebo, and now the results which showed us significant improvement in relapse radiographic progression-free survival, irrespective of the genetic alteration status. That is 13.8 versus 8.2 months. Also, we understand that there is a synergistic interaction between the novel hormone therapy and PARP inhibitor, even without HRR status. The only drawback which this trial showed was there was high incidence of cardiovascular toxicity with 10% incidence with 3% deaths. So the phase 3 trial, the PROPEL trial, was the first trial to come into this category, wherein we are using the first line metastatic CRPC patients, irrespective of HRR mutation, and we are giving them combination therapy of olaparib plus abiraterone compared to a placebo plus abiraterone. This is the recent ASCO GOG 22, which has released the initial data, and it shows that there is 34% risk reduction of progression to death with olaparib and abiraterone. The details of trial are still awaited. So this is how the combination is, with the irrespective of HRR status, is getting into the treatment protocol now. The other study, which is the results are expected, is again the CASPER study, which is again into untreated metastatic CRPC, which is using rucaparib with enzalutamide, and the results are awaited. So what other studies which are again combination is the magnitude trial for niraparib and abiraterone, TerraPro2, talazoparib and enzalutamide. Again, these results are still awaited. So what we understand now is the response rate as monotherapy is 40 to 60%. BRCA2 mutations are more sensitive. And sequencing, as I said before, olaparib can be given after progression after AR targeted therapy, and if the progression is after chemotherapy, rucaparib. Combination with novel hormonal agents may obviate the need for HRR tests, and combination can probably be used in first line too, based on the recently approved PROPEL data. But still, it is still a field where a lot of trials and investigations are on, and it is awaited. Thank you.